Okay, welcome back to TWiGH. TWiGH stands for This Week in Global Health. This week, we're really excited. We've got Hans Rosling on the show. He's a guest panelist, and most of you will know him. He's somewhat of a celebrity in global health circles. Just briefly, if this is your first time at the show, TWiGH is a weekly global health news roundup. We broadcast live every week. If you're watching this live, please feel free to interact with us on Twitter using the hashtag TWiGH. TWiGH stands for This Week in Global Health. You might be watching this on YouTube or listening to the podcast. Welcome to you guys. If you're listening to this on a podcast, just to let you know, there are going to be a lot of graphics and visuals in this particular show, so you may want to watch this on YouTube instead. Okay, you're going to miss out on quite a lot if you're just listening to an audio show. So just to let you know that. A lot of you would have noticed that I wasn't on the last two shows, and the reason for that is I've recently become a dad, right? So I now have... I have a son, which I'm absolutely delighted about. He's fantastic. I love him to bits. But anyway, I'm just telling you that because I'm partially sleep deprived from having changed diapers all night. And if I am unable to formulate coherent sentences, that's the reason. We're going to jump right into the show and introduce the panel. I'll start with myself. My name is Greg Martin. And I'm going to ask each of the panel members just to tell us briefly who they are and where in the world they are. And we'll start off with Hans. Hans, over to you.
Hi, I'm Hans Rosling, working at Gapminder in Stockholm and also professor at Karolinska Institute.
Brilliant. Thanks very much, Hans. Next up, Jessica.
Hey everyone, I'm Jessica Taff. I am a biomedical scientist, and I'm coming to you from the Washington, D.C. metro area today.
Thanks very much, Jessica. And Katie. Katie, talk to us.
Hi everyone, my name is Katie Jackson. I'm also at Karolinska and also in Stockholm, Sweden today.
Okay, so we've got a real global distribution of panelists. And Chris Ronson from the other side of the world. Where are you, who are you, and what's happening today?
Hi everybody, I'm Chris Ronson. I'm coming to you from San Francisco, California. And what's happening is this show. It's the most exciting thing in my life right now.
Excellent. And last but not least,
Amen, sister.
Sulzan, tell us who you are.
Hey everybody, this is Sulzan Bali, and I'm speaking to you from North Carolina, United States, and really excited about this show.
Okay, let's jump right in. We're going to ask Hans, I wonder if you could tell us a little bit about yourself and a little bit about Gapminder, because, I mean, we all know about it, but we want to hear a bit more about it from you.
Well, I started up in Sweden after my undergraduate student in medicine to work as a clinical doctor, but very early I got the opportunity to go to Mozambique and work as a district medical officer. And I did that with my wife and my two young children. We lived in Nacala in northern Mozambique. And that was a life changer. You know, it was very stimulating after independence in Mozambique, 79, 80, 81, to work with very enthusiastic staff with very limited training, actually. And what happened there was that there was a drought, a severe drought in 1981, and people lost almost all food. And in the midst of that crisis appeared an epidemic of spastic paralysis, and that made me researcher. I used to say that I became researcher the 21st of August, 1981 at 8 o'clock in the morning. That's when I saw 15 children and women with a paralysis of the leg that was not in the textbook. So the next 20 years of my life became studies on food security and this epidemic disease which we named Konzo in remote parts of countries across sub-Saharan Africa. And after that then I became a teacher also in global health, and then with my son and his wife Anna and the team here at Gapminder in Stockholm, we have taken on the task to provide a fact-based worldview. We do it by converting data into moving graphics. One of our most famous one is this bubble graph we have on the wall here, where each bubble is a country. So that's more or less what I've been doing during my lifetime. Some clinical work as a doctor in Sweden, a lot of epidemiology in remote rural areas in Africa, and lately now, from October to January, I spent time in Liberia working with the Ebola epidemic.
Thanks very much. Hans, would you just, I mean, most of us will have seen your TED Talk and with the bubbles, but could you quickly talk us through that picture behind you? I mean, just give us the 10-second synopsis, and then we'll jump into some more questions.
Yes, I'll do that. What this is that each country is a bubble. And the color is the continent or the region. Red is Asia, yellow Europe, green America, and blue is Africa. And on this axis, instead of north and south, we have healthy and sick. And on this axis, instead of west and east, we have poor and rich, GDP per capita, life expectancy. And you can see that the countries of the world today spread out from Congo down there with low life expectancy and low income per person, all the way up to Japan and Singapore and Norway up here, which have very high income and good health. And then countries spread all the way, so there are no two groups of countries. My main message, there is no developing and developed world. There are countries all the way from Congo to Norway. And most are here in the middle. Can you see between India and China? Here, the lower middle income countries with India, the upper middle income countries here. And they have better health than they have income. The catch up in health in the world has been more successful than the catch up in money. So we public health people, we should be proud. We did it better than the economists.
I think that was actually one of my favorite presentations that you gave, was one where you had put this data out there and talked about the last 200 years and how things have evolved. Anybody who's familiar with your work, especially your presentations, is no stranger to how passionate you are about what you do. Was that something, I mean, did you always want to go into medicine? Or I know that the transition into being a researcher happened in 1981, but did you always have some idea that this was the field that you wanted to go into as a child? Or did you want to follow in your father's footsteps or be a firefighter or?
No. My father was a low-paid, blue-collar worker, and my parents did everything they could to give a better chance for me and my brother, you know. And I had a very nice, very good childhood. But I wanted, my main interest became very early how people were living. And that came very much from my father and mother, from their very difficult backgrounds in many ways. My mother had a father who was an alcoholic. My father had a happy life, but very meager conditions. I bring with me here the box my father gave me. You know, he worked roasting coffee, and in the coffee he found coins from the whole world. This is a 5 cent from East Africa in the 1950s, and this is from Colombia, you know. And these coins, he used to tell me the life of those who picked the coffee, who dropped the coin in the coffee, you know. So I grew up thinking that my father's workmates were those who picked the coffee. He really had compassion for people living in other parts of the world, you know, in even more challenging life conditions. So that's like my background. So my main interests were not medicine. I wanted to study economics and political science. But then my mother had tuberculosis, several periods of tuberculosis, and she really pushed me against medicine. But what dragged me into medicine was my lovely wife, my teenage love, you know, because she was interested in health service and medicine. So I was pushed by my mother, but I followed my wife.
Well, we owe them a huge thanks of gratitude for getting you into where you are and bringing you through your career and getting you to where you are with Gapminder as well. So.
And Gapminder is very much my son Ola Rosling and his wife Anna Rosling Rönnlund, because they are the one behind the graphics. They have been running this for years, and they also worked a period with Google. You know, but the division is such in this patriarchal world that all the credits go to me, not to Ola and Anna and the team now of developers that they work together with. So I have actually not done anything with this software. A man like me doesn't develop softwares. I am the one who know the background of it, not even the data I do. We have very skilled people or postdocs in different fields here who do the data part. I have studied the content, and I have a skill of presenting. That's my work. We call it here internally, I run the road show. We say, I run the road show. And I go test the material we develop. But it's the team here in the office who develop it.
Okay, well, let me cut in and let me ask you a little more specifically about data, which obviously maybe you're not producing it, but you know all about it. So there's so much emphasis these days on evidence-based health policy and using data to make these policies, and also to go about and use it towards programmatic approaches. Now, with your work with Gapminder, what, in your opinion, are the biggest data gaps that need to be addressed before we can develop meaningful global health strategies? For instance, what do you think is not being measured?
My view is very clear. The problem is not that there are things that are not measured. The problem is that what is measured is not being used and understood. The data gap is not between the reality and the data. It is between the data and the mindset. Let me show you. Let me show you what we have done here.
We love the surprises.
Here you see. This is the world population coming up here. This is the world population. $1 like this is 1 billion people. And in the whole of the Americas, from the South America up to the north, we have 1 billion people. In Africa here, we have 1 billion people. I will push it a little backwards, you can see better. In Europe, we have 1 billion, and in Asia, we have 4 billion people. Just this, many are not aware of. But now, what will happen? We know surprisingly well what will happen. UN Population Division and other fine demographers are good at predicting it. 1958, they predicted 6.3 billion by the end of the century. They were 4% wrong. And look here what they are saying. They are saying by 2050, there will be 1 billion more in Asia. There will be no more in America, no more in Europe, but there will be 1 billion more in Africa. So look there, in Africa, you will double its population in the next 35 years. After this in Asia, the fast population growth is over in Asia, and Asia will not grow anymore. But in the second part of this century, we are expecting 1 or probably 2 billion more in Africa. This is the end of population growth. And you know, there are many people who are not aware that Africa will have 4 billion people, and Europe will still only have 1 here. So I advise everyone in Europe to start being polite to Africans, because they will outnumber them 4 times in the future. And what's interesting also is you see that 80% of the world population will be living in Asia and Africa. And these Europeans and Americans, they will be a minor part, especially North America and West Europe. They will be less than 10% of the world population. This is not my result or my opinion. This is facts. This we know. But it's not being taken into consideration. And many have difficulties imagining that what has happened in Asia already is now going to happen in Africa. Of course, Africa is immensely successful and will get down poverty rate, will get every kid into school, will get better access to a health service and contraceptives. They may be, instead of 4, there may be 3 billion or 3.5 billion Africans, but more or less 3 to 4 times more than Europe it will be. And that is not known, and it's the most basic data of all we have. So my problem is that the data that exists is not being used.
This is really, really interesting, Hans, when you mentioned this whole demographic charts worldwide and talk about fertility rate, increasing in Africa and dropping in rest of the world.
Not increasing. Fertility rate is remaining the same or dropping in Africa. It's the population that is increasing. The number of children in Africa is already down from 7 to 5.
That's really interesting. So my next question for you is going to be, we've talked about the gaps in data. If those are the biggest gaps, what are the biggest opportunities that we can use like this data to make an impact on health outcomes? You know, people have different kinds of misconceptions on how the trends, global health trends are. How can we make an impact using this data?
We can look at the data again. I have another example here. Here I have 10 children. Let me take this up a little. Imagine that these 10 dolls here, that they represent the children of the world. 1, 2, 3, 4, 5, 6, 7, 10. The question is, what proportion of the children of the world, 1 year old, have got the measles vaccination? Is it 1 out of 10? Is it 2 out of 10? How many is it that hasn't got the vaccine? Well, when we have asked that in Gapminder, we run now what is called the Ignorance Project. It was my son and director who said, we can not only be satisfied with fame, we have to measure impact. So we started to measure what people knew. And it was surprising. The fact that it's only 2 out of 10 children who don't get measles vaccination today. That is not known. We have asked the public in West Europe, we've asked the public in North America, we've asked professionals of different kinds, we've asked media, even those in development aid organizations. They think only half of the kids get vaccinated. In fact, it is 83%. So if we just understand this, we see immediately what we have to do. If the successes done to 80% have to go on to those in extreme poverty, those worst off, that we have to reach. So this is what we need to know about these two peoples, or these 20%, or to be precise, 17%. Where do they live? The countries we know, it is in India, Pakistan, Afghanistan, and Sub-Saharan Africa. But where in these countries? It's mainly in rural areas, and it's remote part of rural districts. And that we need to know very much better than we know now. Where do we have the pockets of extreme poverty?
Hans, I want to cut in and ask you about your recent work in West Africa on the Ebola epidemic. I'm sure everyone Ebola is on everyone's minds, and you spent a lot of work teaching people about the epidemic there, bringing facts. You had these fact pods on YouTube, and we are coming on about the year anniversary that the WHO started talking about Ebola being, this upcoming epidemic, and it just got into the media. So I want to ask you, from what your experience in Ebola and or in West Africa working on Ebola, what lessons do you think we've learned as a community, and what perspectives do you have to offer regarding that epidemic and how it was treated and all the epidemiological processes that went on in this outbreak?
Well, one thing, we really can't say that we learned it, but it was re-emphasized. Okay. That is that we have a common interest in the world to avoid health risks. We have a real big common interest to avoid infectious diseases. Because what was special with Ebola is two things. It killed the rich and it kills doctors. That's why it goes beyond the health impact. It stops economies. It reverses development in countries. Schools have to be closed. It's really dangerous, and it threatened global security. We all got that, and that we knew, but we were made to remember it. I criticize myself quite a lot, because I knew well about the outbreak in northern Uganda, in Gulu. I know about the Kikwit outbreak in Congo, Democratic Republic of Congo. But I never appreciated the heroic work done by the epidemiological teams there to stop the disease. It never reached Kampala, the capital of Uganda. It never reached Kinshasa, the capital of Congo. They did it. Now this time, unfortunately, it reached Monrovia, Conakry, and Freetown in Sierra Leone, and that was the problem. That where it took off explosively. So we appreciate very much the heroic work done by World Health Organization and national teams, and also we have to honor organizations like Center of Disease Control and Médecins Sans Frontières. Those are the main players. And what was new now in West Africa, and I have to admit that it surprised me, was the skill of the colleagues and specialists who came from the African Union. New Africa was there. Justin, who came from Tanzania, Margaret Lamuno, who came working for WHO, but with experience from Uganda, Peter Clements, who worked for WHO, those experts who had their own experience from Africa, broad and wide, and were highest professionals, working for the international organizations, of which African Union is one today. They really made a difference. And we turned it around. I think I have the graph here. This is the graph from Liberia. Can you see here how we came in up to August? It was low level. Then it raised like this. This was mid-October, and from here on, I think I better stand up here. From here on, you see, we never thought would it turn around. I came actually at the peak here. I came to Liberia. I didn't make the difference. The difference was already made here, and you see, it went up horribly quick, but it also went down fantastically fast. But look very carefully at the bottom. It doesn't go right down to zero. It's a very tough fight here down to zero. Up here, the fire brigade phase, we called it. There, Médecins Sans Frontières, and WHO were very important. But the more we got down to this detailed detective work here to stop it, it was the national teams, the Liberians, Musa Kafala, for instance, enormous skilled Ebola hunter here, who is now pressing it down. Today it's less than 1 case every second day. And I think very sure that within a month or two, it will be gone from Liberia. So it was a very, very dangerous disease, and it should never have risen up like that had the right resources been there at the first time. And my conclusion is clear why that happened. The budget to WHO, to the World Health Organization, is a joke. Because the World Health Organization gets very little money in core budget, and then they have to take most of their money has to come in project terms. So WHO didn't have enough of their core money to act directly and quickly in the beginning. They had the right people, and the right people were prepared to go, but they didn't have the budget for it. We need to fund the World Health Organization up much higher with a core budget so that they can keep, as they have now, very good professionals, and they can go very fast out in the early phases of this epidemic. We should never have to face such a tremendous high number of cases per day in the future.
I think we should do a round of applause for WHO for that.
And for everybody involved in the fight. Yeah.
Yeah.
Oh, they are. I mean, many people were good. It was fantastic. I would also honor the U.S. Army. It was amazingly, of course, Médecins Sans Frontières was good, IRC, many of these international organizations. But the United States Army, it's very rare that Swedish public health professors sit and honor the Army of the United States. But I worked with very fine people, very dedicated people, and they integrated into the Ministry of Health. Because I didn't work for any aid organization. I worked for the Liberian Minister of Health. This was my business card. Nice. I was a professor and worked directly in the ministry together with officers from the U.S. Army who worked every day together with us. Then, of course, WHO was there, CDC was there. But that team spirit, and also to be standing in morning meetings, having a U.S. general on one side and a Chinese general on the other side, it was a good experience, what the world can do when we come together. Because here it was the whole mankind against a nasty virus. It was not like the tragedy in the Middle East where it's humans against humans. These things we can win, and we should be even better in the future not to let these infectious diseases push countries backwards.
Mm-hmm. Definitely. And you'd made a point on one of your fact pods while you were in there, or while you were in West Africa, talking about how this is, when people talk about public and global health and they say, we need to get down to 0 cases, we don't always necessarily, get to 0 cases. But with the Ebola situation, with the epidemic, that it's absolutely necessary for us to get to that 0 cases coming out.
Yes, and there you need, in the end now, it's not the fire brigade, it's not international organization with branding on their vests and so on. You need fine detectives, that have the heart of a nun and the brain of a detective, And those are there. It was amazing to hear Musa Kafala, who has a PhD, from one of the best U.S. universities, but is deeply knowledgeable about the Liberian society, and how he could interact with single mothers that had been abused and beaten by their husbands and gain their trust, to go and find the children who now was with the father, and it was dangerous for them to go to the father, but he managed to gain their trust and help them to get the children back, and they could be under contact tracing. It's a lot of compassion we need to fight Ebola in the end. And those people are there now. And remember, the support for Ebola has to continue for several months onwards. And also I think UN did well. The whole UNMIR was good with the office in Ghana. It was a preparation that it may have got worse than it did. And I like very much the dedication of the people working in the United Nations, and many of the experts who did the field service in Center of Disease Control was also absolutely impressive.
So, like Hans, one of the questions that I wanted to ask, I mean, we're getting tons of questions on Twitter, and as a professor, I'm sure you're used to giving career advice, and here on TWiGH, we're interacting with a lot of students and young professionals ourselves. So, what challenges do you think the next generation of global health leaders are going to face? And just to tie into one of the Twitter questions that we got is that, do you think the fear of child mortality is still one of the primary reasons for large families in Africa, and is the rapidly growing population our countries hubs for disease outbreaks, and if so, how can we prevent them in future?
Extreme poverty is very dangerous. It has to go. We have to reach every village with a road. They must have a school. They must have some better provision of water and firewood, basic health service, access to contraceptives for their own choices when they see fit. Half of the women in sub-Saharan Africa today do not have access to contraceptives. It's a shame, both for countries and for the international community. We have to get that out. We don't have to push it. We don't have to push them how many children and when they should have. Just give the choice to people. Inform them and let them choose. And they will choose to have fewer children. And you will get a better possibility for them to help these children. And my career advice would be, stick to extreme poverty. Many are needed to help out in extreme poverty because there the resources are limited. That's for the next 15 years. And my simple advice is, priority to periphery. Go far out before you have children yourself, before you have other commitments in life. See that you work some years, very remote areas with poverty and challenges, and you'll find great stimulation. You will find community leaders, you find religious leaders, you find colleagues in health service that are very motivating to work together with. I had that experience from Mozambique from 79, 80, 81. That was a life changer. I also had the advantage as a very young student to study in India, St. John's Medical College, and there participate in public health. So go and join. If you live in a rich country, go to one of the poorest countries, study there, work there, and if possible, marry there and stay. I'm a brain drain. I went away. I had a good life in northern Mozambique, with my wife and the children. And then we returned here. There was a special reason we returned relatively soon after 2.5 years. But when we came back, it was really motivating to see the enormous change, how much better it was today. But this is most important. Then we have the big challenge with the non-communicable diseases in the middle. And the challenge there, if you look here, like this country here, Vietnam, they have a very low income today. The income per person in Vietnam is like United States 1880, but their health status and their disease burden is like United States 1980. Imagine, the health situation is 100 years ahead of the economic situation. And many in global health don't realize that. So I used to say, I love money. I really love money because I know how to use it. There's no way you can get breast cancer screening working in Vietnam and you can get treatment for breast cancer if you don't have money. Mm-hmm. And we need the pharmaceutical industry to have multi-tier pricing so that they can earn their money up in the richest countries, sell their product at a slight profit in the middle, and no recovery of cost for research in the middle, and down in the poorest area we need subsidized treatment by development aid. So this is my idea. If you really want to contribute to the world, go as far as you can down into the poorest countries and the countries with worst health situations.
Fantastic advice.
Yeah, that's good advice. And I just wanted to follow up on what you said about Ebola, how you need to have a heart of a nun and also think about things critically. What kind of skills do you think that the next generation needs to have to do some good global health work? And are we covering those skills in the programs that we have as well?
Well, to cut it short, beside your public health and medical skills, on one hand, economy. You have to count money. On the other hand, anthropology. You have to understand people. and those goes in two different directions. But you have to have a compassion with people and truly understand people's motivation. On the other hand, you have to understand money.
Thanks very much. Hans, this has been absolutely fantastic. I mean, this has honestly been fascinating. I think everybody watching this has been loving it. We can tell from the Twitter questions that are coming through, which we won't have time to get to, unfortunately. But we'll continue this conversation over Twitter. Hans, I want to just throw one question at you that's slightly different. It's a little bit about that, something about you that I think most people don't know. It's a little bit quirky. We understand that you have a history in sword swallowing. I wonder if you can tell us a little bit about that.
I'm a member in SSAI, Sword Swallowers Association International. It's our professional organization, and we have a website. I welcome you there. But there's only needed one sword swallower per 3 million people. That's more or less how we are. And it's by serendipity, during my medical training, we had a good lecturer in radiology, and he showed an X-ray with a sword swallower with a sword inside his thorax. And I got the idea I should learn this. I failed until 1.5 years later, by serendipity again, I admitted that very sword swallower as a patient, and he taught me how to swallow a sword. And I've been trying with the tube, and the tube didn't work. And he said, "Don't you study anatomy? Don't you know that esophagus is a flat organ?" And then I acquired this. This is my bayonet from the Swedish Army, 1850. I've taken away the edge here, and you polish off the edges. And this is flat. This is quite easy to swallow. But don't be too focused on that. It's only needed one sword swallower per 4 million people. We need much more nurses, midwives, medical doctors, public health professionals. Focus on that. We have sword swallowers enough.
We just wanted to say thank you so much for bringing your infectious enthusiasm for teaching and for global health, statistics, epidemiology, everything that you do to the next generation of global health students and professionals, because I think that your the way that you present is such an incredible skill, and it's very, very motivating and inspiring. So thank you again for coming on and sharing your time and knowledge with our TWiGH community. It's been a fantastic show and time having you on.
And thank you for creating this innovative way of communicating on the web. Thank you very much.
Okay, thanks everyone.
Great.
That'll be the end of the show. Remember to come back next week, same time, same place. Looking forward to have you here. And as always, don't do drugs. Always do your best. Don't ever change. And we'll see you again next week. Take care. Bye.